Payor survey. I'm Margaret Pell, Marketing Coordinator here at ReviveHealth, and I will serve as today's moderator. Before we begin, I have a few housekeeping items. First, a copy of our complete 2014 National Payor Survey results and Payor Trust Index can be found on the ReviveHealth website at www.thinkrevivehealth.com/Payor Survey 2014. Today's webinar is being recorded. We will be sending an email with the link to the recording immediately after the webinar concludes. Time permitting, there will be a question and answer session at the end of the webinar. We want to hear from you, so please feel free to submit your questions, comments, and thoughts at any time throughout the webinar by simply typing them into the questions box on the right-hand side of your screen. Please be aware that while we may share your question with the group, we will not include your name or the name of your organization. If you experience any technical difficulties during today's webinar, please refer to the troubleshooting website and toll-free number on the right-hand side of your screen on your control panel. Please use them if you need to. If you are having trouble hearing the audio presentation, problem with slides not advancing automatically, try exiting and re-entering the webinar. At this time, I'd like to introduce our presenters for today's call. With us on the line is Brandon Edwards, President and CEO of ReviveHealth, which is the leading strategic communication firm specializing in health services, health technology, and healthy living. Also with us today is Dan Prince, President of Catalyst Healthcare Research, a top healthcare market research firm. Welcome, Brandon and Dan.
Well, thanks everybody for dialing on. We're going to try to move through our slides here reasonably quickly so that there's time for plenty of questions at the end. And a couple of interesting things this year, just for those of you who have attended past webinars, tracked the survey over time. This is our 8th year, as Margaret mentioned, and this is the first year that a series of questions that are really part of not just how payers are rated, but why they're rated that way and what drives the fundamental trust factors between health systems and payers. So I'm going to turn the mic over to Dan Prince, who's going to walk us through a series of slides on the research methodology and some other critical information that sets us up for the results.
Thanks, Brandon. I'm pleased to be with you. Today for sharing the results, I just want to tell everybody that this research was conducted in the period between January 21st and March 5th of this year. We were from a total of 200 from hospitals and health systems throughout the United States. And as you see on this slide, some of the information came in from an online survey mechanism and reviews with a cross-section of our potential respondents. In terms of the 203 people who were involved, all of them were involved in some way in the management of their organizations, their hospital system. And you see that the majority have titles such as director care. Also had some representation from more senior level executives. Tracks with what the major players that you would assume. This one, I believe, Margaret, advance.
With the wonders of technology, the slides will catch up when we finish. So, for those of you who are on the line, if there's a disconnect that continues through the remainder of the webinar, we'll send out, make sure that a full deck goes out immediately after to all of the webinar
but I am seeing it now on the screen. And you can see represented on this chart, hopefully, that United, Aetna, Cigna, and the Blue Cross plans are well represented in the base of response from this year's study. And it's important to note two things here. One is that we ask people to define the Blue Cross plan that is in their particular state or the one that they do business with the most. That's who they're actually rating when we show Blue Cross Blue Shield in any of our subsequent results. The other thing that's new this year, Shannon, is that upon request from participant from last year, we actually added Blue Card, the post-D card. So for the first time, we're seeing numbers show up for the Blue Card.
Yeah, that was a pretty common comment in our verbatims in past years' surveys that for rating purposes.
Another is that we asked people to tell us whether they were nice-to-have hospital children and I'll show you the results as soon as possible. And is going to give you a little bit of color commentary in terms of why this matters from our point of view.
I would mention one thing as we're waiting for the slide to advance here. It really seems to have moved around a bit the last few years. If we look back in the sort of pre-recession era, maybe up to 2009, must-have hospitals were really defined by services. They were defined by reputation. They were defined by the perception of quality. They were certainly defined by almost regardless of cost or other factors. We've really seen a change in that. There's actually been a fair amount written in Wall Street Journal and some other business publications about the definition of must-have. But we're seeing that very much within the industry in the payer-provider contracting world as well, is that hospitals once considered must-have are missing, right? That's certainly true on the exchange networks, but also true even more broadly in the definition of must-have for commercial contracting. The slide should have advanced now, Dan, if you want to go ahead and walk through that.
Well, the main thing that I want to mention here is that we've got a nice representation of categories with about the response telling us that their organization, whether it's an individual hospital or a system, is considered in the responding as a must-have. And we talked about this earlier. If all 100% came in as being must-have, we would be sort of skeptical as to who would be skeptical about that. So we think this representation undergirds the credibility of the people that have participated in the survey. And if some of you are on the call, I want to say thank you for doing that. But I think it provides us with a good basis for understanding who was involved in the survey process with us this year. So if we can, Mark, let's turn to the central issue that was addressed for the first time in 2014. And that has to do with the issues. And so for the research of those three measures we included here, it's the element or attribute we called behavioral reliability. The specific question we asked is, does this organization make every effort to honor its commitments? And we asked our respondents to rate each of the payer organizations to 5 points. Agree, disagree scale, running from strongly disagreeing, neutral, or neither. And then we had two equal answers on a 100-point scale. If somebody agreed that XYZ company honors its commitments, that translated into a score of a 0. If, on the other hand, they strongly agreed that it honors commitments, we gave that individual response points. And so when we got done matching all the numbers together, we'll give you an array of how the payer company did on first mix, and we think that's coming up here as soon as the slides can catch up to us.
Yeah. One, I wish Alcor's internet was cooperating with us today. One of them was, I saw a great bumper sticker the other day. I don't think any of us went into this thinking that we were going to find some 100% trust rating for the cost system. Going to be some inherent difficulties in the relationship. While we're waiting for that to come up, maybe do you want to talk for a second about where we secured the questions?
Sure, be glad to. I had a research manager on my team in the academic literature to find out what had been produced and actually tested in other settings. And based on that review, we came up with the 3 questions that we asked in this year's survey. One that has to do with reliability, one that had to do with honesty, and one that has to do with fairness. And so what we did is we asked people to rate each of the payers on each of those 3 attributes, and then we created a trust index out of that by combining those answers. Each question weighted equally, if you will, to provide a composite view of how healthcare executives at hospitals and systems really feel about the payers. So we're seeing now, I believe, on the screen, the spread of answers for this first question. And the specific question that we asked is, this organization makes every effort to honor its commitments. You see that Cigna scored best on this measure, and UnitedHealthcare scored worst on the other side of the page. So were there any I'm curious, when you looked at indicative of trust in other industries? Because I mean, our review of the literature indicated that these would be pretty low for trust measures in a typical industry. I will talk more about this obviously later, but I'm just curious if you had an initial reaction when you saw this. Was this higher or lower than you all were expecting? Well, we knew that they wouldn't be at the top end of the scale. Sure. What I was surprised by is that the distribution is really as close. This score at 66 and UnitedHealthcare at 43, but they all seem to be getting a failing grade. If you try to convert what is a 0 to a 100-point scale from an F to a D to a C to a B and to an A. Well, I think actually, to be fair, 66 is a B, right? So that's not it's not a completely failing score. But actually, it kind of goes back to the comment about relative, right? That if Cigna's at a 66 and United's at a 43, what's perhaps most relevant here is that spread, right? That you really have rating at a score that's fully 1/3 lower than the top-rated payer, and that is not a modest delta when you're looking at public opinion survey work, right? What's intriguing is that very few of our responses to any of these payers the top score. So we have the distributions for each of these companies. For example, bipolar definition. You stole my line. And we had about an equal number who said they agreed that UnitedHealthcare was good on this dimension, as said, I disagree that they're good on this dimension. So obviously, when you run those numbers together, you get this kind of midpoint number of 43. But there's a distribution that takes place behind the scenes here, too. So those of you who are on the call, you may have a... So let's go on and talk about the issue of honesty. The second trust question that was included in the survey this year was, this organization is accurate and honest in representing itself and its intentions. And again, we ask people to either agree or disagree with that. And the distribution of scores was very similar to what we just looked at, with Cigna coming in at the high end of the range with a score of just under 66 on our 0 to 100 scale, and UnitedHealth coming in again at the 43 level. So we saw a very similar pattern when we asked this somewhat different question. It balances its interest with ours and doesn't routinely take advantage of us. Here we saw slippage in terms of the scores for all of the payers that were included in our study this year. High water mark being 57, and the low mark slipping to 36, and our rate from Cigna and on the line to UnitedHealthcare at the other side of the spectrum.
So it helped us this year. It's taken features very well. The trust toward payer deposit trust is correct to create a single 1 to 100 point index measuring trust between hospitals and health systems. Hospitals and health plans. So the number one question we've gotten as we've done some media interviews over the last few days is help people, help us understand that as the consumer in in accessing different points in the care continuum, in how their bills are being paid, claims adjudicated, what financial responsibility they have, clarity of what their options are in network or out of network, stress, but at worst case could actually put them at risk of receiving either suboptimal care or suboptimal transfers of care or breakdowns along that care continuum. So we can think of trust as something sort of esoteric. I think one thing we all agree on is that trust in healthcare may actually be much more imperative than it is in other industries because the stakes are so much higher for the people that we serve.
And I'd say as a society at large, we lose when the trust level is low because there's all this friction taking place in what's supposed to be a smooth payment process. And so there's an inherent additional cost that gets added in as a hospital or a doctor's office has to add people to their team just to follow up with health insurance companies because the health insurance company said you're going to get your money in 45 days, and when the money doesn't come in 45 days, somebody has to chase it. And so there's an overhead cost that's associated with the functioning that surrounds this whole process of the relationship between a hospital getting paid by a health insurance company. So I think we as a society and we as consumers who have to pay our own healthcare bills are on the hook for this low level of trust. Yep. We asked a question, maybe just for fun. We asked our respondents to tell us who they believed consumers would rate at the top and bottom end of the trust scale. Specifically, we said, thinking about the consumers and patients you and your organization serve, who do you think the health plan, and conversely we asked separately, who do you think they regard as the least trustworthy health plan? And the two answers are displayed on this page. On the left, we see that Blue Cross Blue Shield garnered essentially 2/3 of the votes, saying that healthcare executives believe consumers have an experience with the Blue Cross brand that tells them that Blue Cross is a good and solid, trustworthy brand. And conversely, it's interesting that the view of the healthcare executives seems to align with their view of what they think consumers are saying about United being at the other end of the spectrum.
Yeah, it seemed like there was really only one meaningful difference here, is that hospitals seem to prefer by a modest margin to have trust with Cigna, and Blue Cross was sort of middle in the pack, I think, on the fairness measure, but pretty highly rated overall, and yet that consumers have incredible trust in Blue Cross plans. I think which sort of matches our anecdotal experience.
Mm-hmm.
But there is, you're right, enormous continuity between how hospitals feel about United and how they believe consumers feel about United. That also matches up very closely with consumer reports in United, which is employers. And they have rated very well in those kinds of surveys, at least in recent years that we've seen. So the Payor Trust Index is about to pop up on your screens here. This was an effort made to consolidate that trust data down into one simple infographic. It's available for download on our site as the slides are. It will also be sent to webinar participants post this event, and it's also been provided to media and our distribution list of people who've expressed interest in the survey results in the past. So just kind of put that up there as a mention for you to, how do you present pretty complicated research information in a way that can be absorbed by an employer or a broker or your board or different audiences. That infographic may be a good tool for doing that with them. So now we're going to shift into some of our legacy questions. Right, we move now from the trust index questions into questions that we've been asking for 8 years, or at least most of them have been asked for the full 8 years. And it's really a series of best-worst questions. Who's the best payer overall? Who's the worst payer? Both overall in terms of the total relationship between the health system and the health plan, but also on some individual factors. So the trend information on this, which we'll show you the wrap up in a couple minutes, is fascinating when you see the year. In this year, Blue Cross Blue Shield plans are not going independent are overall 11% that's the worst ratio. 40% considered United Healthcare the worst for all. 6% considering the best. Those two sets of plans, it's pretty dramatic ratings. So in past years we've looked at that and said, gosh, it's hard to tell what's driving that, right? What is driving those best-worst ratings? And so part of our effort this year in the Trust Index was to answer those questions, but also part of what we do is unpack that then in a series of follow-on questions. We asked about paying hospital claims promptly, right? So there's a lot of factors to a health plan, health system relationship. One of those is prompt payment. What we had, interestingly, 49% of respondents said Blue Cross Blue Shield plans are their best paying promptly. Only 8% considered them the worst. Conversely, 31% said United was the worst. So you're part of obviously what's driving dissatisfaction with United is a lack of prompt payment, and a large part of what's driving satisfaction, we think, with Blue Cross plans is prompt payment. And I think we've talked about this a little bit or hinted at it in past years, given their market share where independent plans exist, start to be rated by hospitals, right? My rate may not be great, but I get paid promptly. I know when I'm going to be paid. They tell me the truth, right? And there are notable that we have to acknowledge. So the next question we ask, and I think this has always been a meaningful driver of the best worst ratings, but we ask hospital executives to rate negotiations. And this is very much sort of what we got here is 37% of respondents said that Blue Cross plans have the best reputation for honesty. 46% said that United was the worst plan that they deal with as it relates to honesty and candor in contract negotiations. So literally almost half. There isn't any other payer above 15% when it comes to worst reputation. So, clearly that is a big part of what's driving this dissatisfaction. The next thing we look at is responsiveness and timeliness in contract negotiations. Again, Blue Cross Blue Shield plans jump out at 35% rated the best overall for that timeliness and responsiveness. The next best rating is Cigna at 18. United is ranked far and away the worst at 38% on responsiveness and timeliness.
Negative 38.
Yeah, sorry, a minus 38% for worst, and the ratio of worst to best there is almost 5 to 1. So not just rated poorly, but rated poorly by huge margins when you consider the relative positive scores as well.
And remember, 9 out of 10 of our respondents said they're doing business with UnitedHealth. So this is a rating based on input from a lot of people.
Yeah, you're really looking at a couple truly pervasive health plans, right? Mm-hmm. Going back to our sampling, everyone has a contract with United. Everyone has a contract. I mean, I'm overstating a little bit, just to be dramatic, but those are the most prevalent plans: United, Aetna, Cigna. You start to drop off a little bit when you start dealing with a Humana on the commercial side. But you also have almost everyone has a Blue Cross coverage, whether it's with WellPoint, own plan, or an independent Blue. So then we look at a few denials, and this is again where Blue Cross comes out. 40% of respondents say Blue Cross is their best payer when it comes to processing claims with fewest denials. 34% say United is their worst payer when it comes to processing claims. It was second with a minus 18, meaning the difference between United at minus 34 and Humana at minus 18 is just about 2 to 1. So it's dramatic, but a little less dramatic than some of the other ratings. Here's where I think personally it gets a little interesting is when you start looking at rates. We asked the question, who has your best and worst payers as it relates to hospital inpatient care. And so the first time we've broken rates into inpatient and outpatient. This is where Blue Cross really takes a dive on the numbers. They go to minus 39 when you look at hospital inpatient care, and minus 37. So they are rated the worst payer overall for hospital inpatient care rates. United is a close second at minus 26, and then WellPoint Anthem at minus 15. We have, but interesting is Aetna jumps up now to be the best payer as it relates to inpatient rates, 29% rate Aetna the best overall. But what's really curious to me is you still have Blue Cross Blue Shield tied at second with 16%. So there are some hospitals out there who would say their best rates come from Blue Cross plans, which I think is sort of a little bit unexpected to me given what market share for those plans looks like. Now, if you flip over to outpatient care, it's interesting, almost a mirror image, slightly better rates, slightly more hospitals rate Aetna as better on the outpatient care, their best payer, slightly more rate Blue Cross worse on outpatient care, but those numbers are very consistent. So, what we're seeing, interestingly enough, is hospitals generally rate Blue Cross plans pretty well, except on rates. But there's not a mistrust issue that's driving the problem. With United, there's a little bit of a rate problem here, but what it really seems to come down to is a lot more non-rate issues, behavioral issues during negotiations and after negotiations, and very much issues that we put into the trust bucket. So then the last two factors, that we'll look at, and then we're going to transition back to some trend numbers, are physician payment rates. Interesting, your best and worst physician payment rates. Blue Cross Blue Shield plans are ranked as the best for physician rates, right? So there are some markets clearly where Blue Cross has very low physician rates, and some markets where they're considered to be pretty good. United is second on the worst side, followed by WellPoint, Anthem. So a fair amount of rate consistency, depending on whether it's outpatient, inpatient, or physician. You like to see that continuity in terms of confidence in the result. It certainly helps to explain some of what's going on with the United ratings. Then the last question, which comes back to our earlier trust comment, is who's the best payer for hospitals to partner with on those ACOs, medical home, at-risk arrangements, capitation, the mythical population health management bucket that have a lot of different elements in it. This really, I think, is where trust comes into play, perhaps more than any other question. 37% of say that Blue Cross plans are absolutely the best payer. 39% of hospitals say that United is far and away the worst partner for new initiatives, and only 6% considered them the best.
And Brenda, don't you think that ties back to the trust issue, of course?
I think it has to, right? Like, if new initiatives are all about exploring unmapped territory together and assuming some level of risk, right? Even if it's not financial risk, you're going to be reluctant to do that with someone that you don't trust. And this, I think, is where some of the questions that we've explored along the way become, you can see this stark change. Up on your slide now, you should see best worst at claims payment, prompt payment, and best worst at honesty, candor. And what we want you to look at are a couple factors here. One, look at the Blue Cross Blue Shield rankings over the last 5 years, right? If anything, prompt payment, they have improved as the best payer to do business with. United had, I think, really marked improvement from 2010 to 2013. There was, some different leadership in United Health Networks for a good portion of this. When Michael Boyle was there, we saw really a change for a lot of hospitals in the tone and tenor of their relationship with United, particularly from a network and negotiation standpoint. Look at the dramatic drop-off in 2014 in prompt payment. 9% erosion in the worst category. And look at honesty, candor. That's a 12-point drop in 1 year. It almost ties United for its worst ratings ever in the survey. So, if we flip now to the next slide, I think you'll see some trend data around responsiveness and timeliness. I think there are two things to point out here overall in trend. One is that Blue Cross plans have stayed fairly steady with some marked improvement in honesty, candor. The previous question. And some marked improvement here in responsiveness and timeliness. What's dramatic is the year-over-year changes in VOS. So it's an accident, right? When you see this kind of change in every aspect of relationship and trust, you have to assume that it is in some part driven by a corporate strategy or change in leadership or perhaps both.
And those numbers are statistically significant from our standpoint as the researchers.
Content here.
Yeah, we carried a few questions forward or modified them slightly just to add a little more color to the full package here. And this is not going to take long because we're very interested in having your reactions and the questions you might want to pose for us. And I believe you can type those in. Isn't that right, Margaret? So if you've got questions on your mind, go ahead and start typing so they'll soon show up here on our screen. In the meantime, I was just going to mention that when I look at this particular slide, what I'm seeing here is the mood that exists among managed care executives at hospitals and systems around the country. Basically optimistic, optimistic, or does it lean towards the pessimistic side? Well, you can see that about a third of our respondents are expecting that their rates will actually drop. They'll drop, a few percent over this next period. Or half expects some level of increase, above or beyond the rate of medical inflation. So the general mood is surprisingly optimistic, given all the chaos that's going on in healthcare and all the negotiations that have been taking place back and forth.
Yeah, and I think, to me, it's sort of fascinating that you get 45% of hospitals saying that they're going to get rates at medical inflation. Now, what's interesting is obviously that number's moved, right? Medical inflation was 9% 5 years ago. It was 6 or 7% 3 or 4 years ago, and now we're in sort of historic lows as it relates to medical inflation. So even staying even with the market is a lower trend overall. Clearly, this isn't what insurance companies are telling employers or business publications overall, but we're seeing a real moderated expectation from hospitals. And keep in mind, half of these hospitals say they're must-have. So the same people who believe they're must-have in a market expect their rates to be, pretty consistent with medical inflation. There's a few, 8% say that they think their rates will grow faster than that, faster than medical inflation. And there's a few who see a need for some meaningful adjustments. You see about 76% say that they're looking for 4 to 7, and about 12% say they're looking for 8 or above. 8 or above now represents something pretty north of medical inflation. That said, there's new healthcare spending data coming out all the time, and it'll be really interesting to see what this exchange population and the newly insured do to healthcare spending over the next year.
And Brandon, that 12% you just cited is 12% of a narrow piece of the
12% of 8%. That's right. Right.
And
you're talking really about a point, about 1% of people.
While there's a slightly positive skew to the mood, we also know there's a lot of cost cutting going, or whatever these rates may turn out to be. So we asked another question, which we're showing on the next slide, which is, if your largest payer, based on net revenue, represented 100% of your commercial business, would your hospital health system be profitable based on current rates? And 2/3 of the respondents said that their organization would, in fact, at least break even and be heading in the profit direction. So that's actually a pretty good sign of financial health in the set of hospitals that participated in our study, I think.
Yeah, I think it's interesting on a couple levels, right? We've asked this question in past years slightly differently. As we said, would you meet your profit margin target? And the answer was always overwhelmingly no. This year we asked it differently. Would you be profitable, period, if 100% was commercial business? So what this tells us really is that 2/3 of hospitals out there, their biggest payer contract has rates high enough that it offsets the cost shift from Medicare and Medicaid and the uninsured, right? For those other 26%, though, they have a whole different cost shift going. And that cost shift is second and third tier payers who are helping to fill the gap created. If we were to cross-reference that with the previous slide, the people who the largest increases are almost always who have that secondary cost shift occurring, right? High rates with number 2, number 3, number 4. To offset inadequate rates from their largest payer, which at least in most markets is a Blue Cross plan. Certainly not everywhere, but most markets.
The next slide talks about roadblocks giving better payment terms, and there's numbers that jump off the page here. It actually appears on your screen.
It will jump a lot.
So we're watching from here.
The question we're going to focus on here that, this is really for the first time, what are the roadblocks in your organization for its better terms? And we have some UP as pitfalls. This is really the first time that we've lined up a series of potential roadblocks in them from better payment terms, whether that's rates or language or just a better relationship with their payers overall.
one answer was that what we'd like is more reliable benchmarking data about our competitors and the contracts that they have in place with the same payers that we're trying to negotiate with. 2/3 of our respondents gave us that as the most frequent answer we got.
What I thought was interesting here, so we gave I think, what, six options that you can see that should have just popped up on your screen if it hasn't already. 2/3 said, reliable benchmarking data about my competitors and contracts overall. But we've got half who say public perception in the market, right, that they're in their market, hospitals or their hospitals perceived as being expensive. 30% physician support, 31% the ability to tell the story to critical audience. The results argue that the bottom 3 or 4 are very much about communication and the ability to tell that story, right? So even if it's just to tell the story to your own board or C-suite. Now, I think you have to tie it back to the first factor. If you don't have good benchmark data that you're confident in, it's hard to tell the story, right? I mean, we talk about that a lot with our clients, is more is not a strategy, right? The strategy is benchmarked off of something. And what is that, right? But those bottom factors are very much about confidence and inspiring loyalty and resolve in different audiences, and combating a public perception that, I would argue no one believes hospitals are inexpensive, but whether hospitals are being paid fairly for the market and whether future increases are consistent with medical inflation, that ought to be a good balance to public perception. But I'm not sure it's a story that's been well told in a lot of places, or broadly across the industry.
Well, and this slide would suggest that our respondents agree with you, Brandon, that they would like to be able to do a better job on telling their story and connecting with key stakeholders. And there's lots of different kinds of stakeholders. We may come back to that a little later in the Q&A. But in the interest of time, I thought we'd see if we could move to, I think it is one of the last 2 or 3 slides we have for you today. And this is a question that we've asked in the past. I'm not sure if it's exactly worded the same this time, but it does establish a picture, a snapshot, if you will, and I think we could draw some inferences from the issue around criteria. And the specific issue that we asked our respondents to respond to is, are they having to meet certain quality criteria as a contracts that have at their top 2 or 3 of those contracts as it relates to opportunity and risk. And so we're hoping this slide will pop up any second, because what we found is that about half of our survey participants said they have contracts in place where quality criteria are a definite part of the contractual relationship. In other words, the payer is looking at their quality indicators as part of keeping that relationship intact. And we would suspect over time that that number is only going to grow. It's a phenomenon that's going to become very, very widespread.
Well, and risk is all the rage for discussion, right? And one of the things we've all learned the hard way is that risk is in the eye of the beholder. If you want your schools to all have downside risk, if hospital have risk, and you have the ability to earn more than what your base rate is, and it was sort of, it was kind of interesting. We had 60%, almost 2/3 of the hospitals say they have opportunity for upside. That means some sort of for either upside or a mix of upside and downside. In either case, that respondents saw more opportunity there than just pure downside. And then this is our last slide, be coming up here in a second on health. may not be purely purely by choice, right? Narrow networks are sometimes foisted upon us. Sometimes we choose them, but it is very prevalent. And in fact, we had 47% say they're currently in narrow networks. Another 13 say they're planning and preparing to implement. That's 60%. That's almost ubiquitous, among this audience. The population health strategies for employers and other groups were said to be in preparation or in place by half. Also, I thought pretty fascinating. You had 56% of hospitals say they either had population health programs in the works or already launched. So again, it's moved kind of inside to outside. In hospitals who did this for themselves, ultimately, this needs to drop off. A third of hospitals say that participating either stage 2 or stage 3. The least only 33%